Welcome to A New Prescription, where we explore modern healthcare, cutting-edge medical research and technology, and the complexities of healthcare politics. Join us as we provide insights and solutions to help you navigate the American healthcare system.
Hello, everyone. It's another episode of A New Prescription. I'm here with my son, Andrew. This is Dr. Leonard Zwelling. We are covering a real important topic today. Obviously, we have been covering cancer risk and cancer prevention, and we have not touched upon the most important group of diseases in the United States, which is still cardiovascular disease. So I've asked a friend of ours, Dr. Susan Gilchrist, who's a professor at the University of North Carolina of cardiology. She's also the director of cardiovascular prevention and co-director of cardio-oncology, which is an important new field, and how I met Susan through my wife, Jeannie, when they worked together at MD Anderson. And what we want to talk about today is assessing cardiovascular risk as it can be done in a doctor's office and when this needs to go up the food chain to a cardiologist. So Susan and I have already talked, and I want to talk a little bit about this assessment and what is exactly a risk calculator. That's what we need to know first, I think.
Okay. Well, I'm happy to give that info. First of all, just really glad to be here. And, cardiovascular prevention is close to my heart. I think most of the time, cardiovascular disease is preventable. And, that's what a lot of our topic is going to be on today. How do I keep from having cardiovascular disease be a part of my life? And so one of the ways in which physicians think about cardiovascular risk and what testing they should do is they base it on someone's risk calculator. They have calculators that allow them to say, okay, is my patient at high enough risk for me to do additional testing? And then calculators can also be helpful for patients if they want to use them to kind of say, oh, like what are the intrinsic things that cause cardiovascular risk? Because the calculator is basically what are the risk factors, and then based on the risk factors, what is my risk? Usually it's over a 10-year risk, and then you can also have lifetime risk. Our traditional calculators are the ACC-HA calculator, and when you can even Google this, it will look at what your age is, because age is a big predictor of cardiovascular disease. It'll look at what your gender is, and then the main risk factors that we think about, like blood pressure, cigarette smoking, diabetes, and cholesterol. Um, in that
How
calculator.
does one acquire the calculator? Is there a specific website people can go to on the computer to find it?
Yeah, I mean, you could Google ACC calculator, it'd probably come up. I mean, I'm not going to do it right now, but it's a
It's the
pretty,
American College of Cardiology.
uh-huh. Yeah,
Okay.
so you can look at a 10-year risk calculator. I think the reason why I wanted to bring this up is that, first of all, when you go to that calculator, you can look at what the risk factors are if you're not already aware of what they are. But what's been really cool is that we've actually come up with even a better calculator. It's called the Prevent Calculator. It's come out in the last year. And the thing that we like about this calculator is that it's accounting for things that when the original calculator was sort of created, we haven't had all this obesity epidemic, right? So now cardiovascular, kidney, and metabolic syndrome tend to be a bit more pervasive in our society. And so this calculator takes into account kidney disease. It takes into account, what your body weight is, so that we can get additional sort of granularity on your risk. It also starts at the age of 30, so you can kind of look at what your short-term and long-term risk is at a younger age, because we know that really cardiovascular prevention is about starting early and staying consistent. And so if you're thinking about your traditional risk factors and keeping them optimized throughout your life, then you're going to do a better job. So having, you know, um, calculators and risk prediction strategies and talking about that early in life, I think is important. Also, it's more accurate for different races and ethnicities. So traditionally, it was just a white population that we had a lot of accuracy around. But I think that based on the ability to look at broader populations, broader risk factors like cardiovascular, kidney, and metabolic disease, the prevent calculator is going to be important in the future for clinicians. One of the things, the reasons I wanted to bring this up is that if you're a patient and you're going into the clinic, you know, sometimes a clinician will say, oh, well, you have hypertension, it needs to be treated. Or they may say, oh, you have a 7% risk of heart disease over 10 years. You need to start getting more aggressive. And so, what in the world does that mean? And so, one of the things I wanted to talk about is like these calculators provide a risk prediction to help patients and physicians talk about how aggressive you need to be. And I'll give you an
Is that really
example.
the
Go
way
ahead.
this should go? So the individual patient uses the calculator and shares that information with his or her doctor begin to develop a strategy both for prevention and, if necessary, treatment. I assume that's how this would go for most patients.
It's usually the opposite, where the clinician will calculate the risk and then we'll talk to the patient about, for example, why should they be on a cholesterol lowering medicine? Nowadays, we don't like say, oh, well, we use a two-pronged approach. One is we look at the absolute cholesterol level, but number two, we look at what the patient's risk is, cardiovascular disease. And if they have a higher risk, then they need to be treated more aggressively for cholesterol. It makes sense. But what I want patient individuals listening to this podcast know is like if your doctor says you're at intermediate risk for cardiovascular disease, and that's probably like a 7.5% risk over 10 years, you know, what is that? How did they get to that number? That's based on that calculator. So, and for many informed patients, they can do the calculator themselves if they really want to know. But generally speaking, a clinician will do that in the clinic. And then let's say a patient says, I don't want to be on cholesterol medicine. I've heard all these things about cholesterol medicines. I don't want to go on cholesterol medicine. Then, they have a clinician can say, well, based on your cholesterol levels, based on your tenure of risk that we just calculated, you going on a statin or another cholesterol medicine will lower your risk by this much. So you're actually be able to give more specific information about how treatment could potentially affect outcomes. And so, um, and someone that's doing prevention for a living, we look at risk calculators, but in general, we use a risk calculator in addition to the other things. How's the patient doing? What's their lifestyle? What's their interest in thinking about their risk versus, you know, you have to engage the patient and what's going to work for them. So sometimes talking about their risk works. Sometimes it scares them and they have to talk about something that they can engage in. So a good physician is really going to use everything in their armamentarium to help patients be healthier. And then this is just one of those tools.
Let's talk a little bit about cholesterol, because certainly there may be nothing more mysterious when it comes to heart disease than cholesterol. So most of the time nowadays, when people get their blood drawn, they get what's called a lipid panel. What
Yeah.
is a lipid panel? What's in it? What matters? And what has to be lowered if it gets high?
Yeah, that's a great question. I think what's in a lipid panel is your total cholesterol. That's all the lipoproteins that are within your blood. You have your HDL or high density lipoprotein cholesterol. That's what we usually see is your good cholesterol. You have LDL or low density lipoprotein cholesterol. That's your bad cholesterol. And then you have triglycerides. And then sometimes they will add sort of non HDL cholesterol, which is in general all of the bad cholesterol. So it's total cholesterol minus HDL. So HDL is considered good cholesterol. The thing that frustrates me and it's still part of the dynamic of looking at a lipid panel, is a patient will come to me and say they may have a very high LDL, um, but their ratio, their good to bad, is not out of whack. And what I tell people is your good cholesterol, your HDL cholesterol, is really a marker of your overall sort of good health. Like HDL goes up as you're more fit. Um, but having a high HDL does not protect you against a bad LDL. Bad LDL, meaning a high LDL. Um, and if you have familiar hypercholesterolemia, I'm talking about an LDL of 190. If we're talking about a patient that has heart disease already, their LDL should be around 60. So that's a big spread, right? And that's why there's so much controversy, is because most people are in the middle. They don't have a family high cholesterol 190. They aren't low like in the 50, but they're in that 130 range or 140 range. And that's where it gets complicated, because technically speaking, we would want all of our patients to have an LDL of less than 100. But again, based on calculators and risk and things of that nature, um, the LDL sometimes, just goes untreated in that intermediate range. And so we have to say, how high risk is this patient for a future cardiovascular event that we need to get their LDL very aggressively controlled? Um, Triglycerides are, and we'll talk about LDL a little bit more, but just to finish this off, triglycerides really are highly variable. You could have a half a glass of wine the night before, and your triglycerides could be through the roof the next morning, even though you fasted. You could exercise, and there would be a change in your triglycerides. And so there's a lot of variability in triglycerides. Triglycerides are not an extremely strong marker like LDL, and we tend to be a little bit more liberal or pay less attention to the triglycerides, except in patients that have known coronary disease. The
When do
big,
you when do you decide that the numbers are sufficiently high? Which numbers to start with? I assume
yeah,
the LDL is most critical.
yeah.
And where do you start with treatment? What's the first thing you usually offer a patient?
Yeah, I think the first thing I talk to a patient about is, number one, um, I tend to try to start with a positive. So if their HDL is high, I tend to say, it looks like based on this that you're an exerciser and your HDL looks pretty good. So congratulations on that. And that's sort of a conversation to talk to them about what their exercise really is, to confirm that. Then when I talk about their LDL, I mean, before I've even looked at that number, um, we've talked about what their family history is, what their concern is about their family history. We've talked about what their 10-year risk is. Um, and my sort of, based on that, we have a conversation about whether or not it's realistic or not to get their LDL um, lower. And if there is sufficient risk, they need to go on a cholesterol medication anyway, if based on the calculator they're at intermediate or high risk for cardiovascular disease. And so it's a little bit complicated, because we don't just look at LDL per se. If the LDL is, let's say, okay, um, but they have an intermediate to high risk of having a cardiovascular disease, like let's say they have diabetes, they're automatically intermediate to high risk. And so they need to be on a statin irrespective of what their LDL is. And so in some cases, when we have someone that has coronary calcium elevation, has diabetes, has a strong family history, and we're worried about that, in addition to their 10-year risk, we might say you need to get an LDL of less than 100, and you need to be on a statin, irrespective of your LDL. For patients that in general are, I think the hardest ones is when someone will come to me, they're not diabetic, they have a 10-year risk score that's not super high, and their LDL is around 130. that's a time when you're always going to say, you need to have a better diet and you need to eat more avocados, you need to take in nuts, you need to, put in fiber and oatmeal into your diet. These are things that lower your LDL and you need to avoid high fatty foods. And then a patient might come back to me and say, hey, I do all those things. I exercise, I have a really good diet. How can I prevent heart disease? Is 130 okay? And then what I do is I'll say, well, let's look at a risk enhancer. And that's a sort of a buzzword for having other strategies to help us understand what the risk is other than just spitting out a score. So there are two ways to do that. One is to actually have them have a coronary artery calcium scan, which is a non-contrasted CT. Costs about $100 out of pocket. There's very little radiation, and you get to see whether or not they've had a buildup of atherosclerosis in their coronaries. And if they have, and they're kind of in that borderline of whether or not you should be on therapy, and they have a borderline LDL, that sort of tips you over to say, yes, you need to be on cholesterol medicine because even though your risk isn't coming out as intermediate or high, you have calcium that's building up before you should based on your age. And we know that atherosclerosis or coronary calcium is made up of lipids, it's made of inflammation, it's made of platelets. And so we know that statins in particular are going to lower your cholesterol and lower your inflammation. And so you should be on one based on that coronary artery calcium score. So we leverage other tests when there's a question about how aggressive to be when, calculators aren't really doing the trick. And a lot of times they don't. We need more information. Um,
When
another,
when do you decide to go beyond statins to other drugs?
um,
What would pull the trigger on that?
yeah. So I guess I would back up just one piece and say the very first thing one should do if exercise and diet is not working to get to goal. And, we've had a conversation with the patient that they're agreeable to go on some sort of medication. Statin therapy is basically where we should start. And the reason is because it has very good consistent data on cardiovascular event reduction. Now, what I tell my patients is, I don't put you on medicines to lower your LDL. I lower I mean, obviously I do, but why do you go on medications? You go on medications to lower your risk, right? So this mechanism will lower your LDL, but ultimately, I'm trying to lower your risk. And statins have been proven over and over again to lower your risk. So that's that is my framework for how I start the conversation around statins. Now, when do we go to something beyond a statin, which we've gotten very lucky in the last few years to have more drugs that are powerful to get the LDL better controlled and, more importantly, lower cardiovascular risk. We actually had a few cholesterol lowering medications on the market that lowered LDL, lowered triglycerides, but they didn't change cardiovascular risk. So, why be on those medications to lower a number when they're not lowering what you came here to see me, which is to lower your heart risk? So luckily, statins lower your cardiovascular risk, and then PCSK9 inhibitors, which interrupt sort of LDL receptor recycling, they are a antibody that basically goes after the LDL receptor, and in that way are able to lower LDL cholesterol in addition to statins. So it's not just like a medication that's um, not as powerful as a statin. It is as powerful as a statin. It can lower your LDL cholesterol by about 50%. So if we're in a scenario where we have, for example, a patient that has had a heart attack, this is mostly for patients that have had a heart attack, and they're on statin therapy, but they're not getting to goal, then putting them on a injection um, such as a PCSK9 inhibitor, can lower the LDL even lower. And the goal for someone for secondary prevention is less than around 55. And so it's a very, very aggressive goal. But we're very lucky right now that we have a lot in our armamentarium to fight high cholesterol.
Tell me about lipoprotein A. What is that? Is it something that's measured in a routine panel?
Another good question. It's not measured in a routine panel, but there's been a lot of press about it lately. Lipoprotein A is very similar to LDL cholesterol. We used to think that it was basically just like so much like LDL that it really didn't give us any additive information over LDL, so it wasn't measured as much. The other thing that's interesting about lipoprotein A, which is very similar to LDL, but it has an additional moiety that basically is supposed to or has shown to have a little bit higher thrombotic risk. And so because of this extra moiety on the lipoprotein A, or similar to LDL molecule, the epidemiological data has shown that lipoprotein A, independent of LDL cholesterol, increases the risk of cardiovascular disease. This has become a natural target for drug companies to try to target lipoprotein A, and there are ongoing clinical trials to see whether or not targeting lipoprotein A will lower cardiovascular risk in patients that are already treated for LDL. I think the other thing that's important to know is that lipoprotein A is genetically your level is basically inherited. And so because of the genetic predisposition for normal or high lipoprotein A, I use it in two scenarios. One scenario is a patient comes into my clinic and says, I have a perfect diet, I'm normal weight, and exercise, and my LDL is very high. I'd say, well, maybe there's a genetic component to your high cholesterol. Let's get the lipoprotein A and let's see. And if it's elevated, that tells us, it gives information to me and also to the patient that, they could have the best diet and exercise in the world, but they're going to need to be on medication to lower their cholesterol because it's genetically there. The other way I'm using lipoprotein A is because it's now an independent risk factor. I'm using it in patients, like I talked about before, patients that have sort of that intermediate LDL cholesterol where they don't want to go on treatment, and whether or not they would benefit from more aggressive control. If their lipoprotein um, A is elevated, then I get their LDL to a much more aggressive goal. Because I know intrinsically, just like someone with coronary calcium is at higher risk because they have existing atherosclerosis in their arteries, and I need to get their cholesterol lower, someone with lipoprotein A that's very elevated, they also are at higher risk for cardiovascular disease. So I'm going to be much more aggressive with their targets, not just their cholesterol, but with their blood pressure, with their glucose control. Because to me, it's an independent risk factor. And so, again, I use the risk calculator. I use coronary calcium if I need it.
The question of fitness always comes up when it comes to prevention. So, can fitness really be measured, not in a world-class athlete, but in everyday people that walk the streets? If it can, how? And are the wearable devices useful? Do they really help?
Yeah. So let's talk about cardiorespiratory fitness. And one of the things that's so sad about, our risk calculators is that it really doesn't uh, talk about or even think about one of the most important predictors of cardiovascular disease, which is how fit you are. And so in my clinic, that's something that I do definitely talk about. But what is fitness? Cardiorespiratory fitness is really sort of your exercise capacity. It's how well, as you're exercising, you're getting oxygen through your lungs, through your heart, to your skeletal muscle to do work. So the more efficient you're able to get oxygen to all your vital organs, the more fit you're going to be. And so we assess that with cardiopulmonary exercise testing. Sometimes we can estimate that also with just treadmill exercise tests. And what you do is you get someone on a treadmill and then you increase the speed, you increase the grade, and you can estimate someone's fitness when you're not using a breathing to look at their oxygen consumption. You're using a measure called METs or metabolic equivalents, and that tells you how fit you are. If your METs are higher, one MET is you are sitting still. And so as you do more METs on a treadmill, the more fit you are. One of the things about a MET level that you achieve on exercise testing is what we've shown with epidemiological studies is you really need to get over sort of this 5 to 6 METs. If you can't get to 5 or 6 METs of exercise, you are potentially at very high risk for heart disease because
What
that's
does
sort
that
of
look
that.
like? What are 5 or 6 minutes look like in I don't know, sit-ups, push-ups? What would
eh,
6 minutes look like?
Yeah, so that would be starting to do it depends on the grade and the speed. It could be a really fast walk. It could start to become a jog. If someone can't even start moving at that level, but again, it's based a bit on the treadmill. It's based on your age and your sex. So, but there is sort of like a threshold effect of if you can't get on a treadmill and start getting past that um, first 3 minutes, you are really at high risk for heart disease. And that's been proven over and over again. Um, One of the things that is a limitation of, even though we know it's a very strong predictor, is most people do not do treadmill tests when they're asymptomatic because there's no indication for it in medicine. And so, physicians don't get reimbursed just to check a fitness level in an asymptomatic person, unfortunately, because I think it gives good
Yeah,
information. So, but
maybe they should.
yeah, but because it's not reimbursed, we don't do it. And so there's, while, we can look on treadmill and see what the MET level is, if patients aren't routinely getting, fitness testing, then it's hard to know what their absolute fitness level is. So what do we do in an asymptomatic patient if they want to know what their fitness level is? And we now have devices like Apple Watches that can estimate your fitness. What I like to tell people about things like the Apple Watch is that, it's an algorithm that looks at a couple variables. It looks at your heart rate, and it's also looking at your heart rate in relation to your walking or your walking speed. Um, and so it then will estimate what it expects your heart rate to be at maximal walking or running speed. Okay. And so it's not a precise measure of what your absolute fitness is. It's a relative measure of your fitness. So tell people that it, while the VO2, or in this case, it's the VO2, not the MET level, but you'll get a level. And then that level is a good, don't take that as like, oh, that's my level. That's just where the computer is starting. But I do think it's good at sort of over time saying, what is your fitness going up or down? Because once it learns more about you, it has that level of fitness, then it can track over time whether or not you're increasing or decreasing your fitness based on those measures. Now, some people come to my clinic and they say, oh, I've lost all this fitness based on, the Apple Watch or some other watch. And what I tell them is, what's going on with your heart rate? If I put you on a beta blocker, your heart rate isn't going up and down anymore. So the watch isn't accurate anymore. So there are many things that can interfere with accuracy. So if your fitness all of a sudden dives, then there's probably something going on. Maybe you didn't sleep well the night before and your heart rate's up, right? So I like to tell people it's not it's an estimate. It's pretty good for tracking over time once it gets to know you. But let's see. I think, can you hear me?
Yeah.
Okay. But it's not perfect, and you have to be aware that because it's related to your heart rate, there are things that can mess up what the fitness level is, even though your fitness hasn't changed, if that makes sense. And so
Yep.
I really like it as a measure, but there are limitations just because we're not reimbursed to measure fitness in asymptomatic people.
The one thing that everybody seems to measure, no matter whose office you go to, and that even includes the dentist lately, is your blood pressure.
Yeah,
Tell us, a lot of people know what their blood pressure is, but have no idea what the numbers mean. What
yeah.
do the numbers mean? And when is it time to do something about those numbers in a doctor's office if they get a little too high? And what's too high mean?
Well, I think this is really timely because the 2025 guidelines on hypertension from multiple organizations has just come out. So I think this is really timely. And I think one of the reasons why it's timely is that we're tightening up what our blood pressure should be. It used to be um, sort of a higher threshold. And I don't even talk about what that is. I want to talk about what the optimal blood pressure is. Your optimal blood pressure should be 120 over 70. Like if you're above that, you have high blood pressure. 130 over 80, anything over that is hypertension. 140 over 90 is, stage 2 hypertension. And so our cut points for high blood pressure have gotten lower because why? Because the data has shown in clinical trials that lower blood pressure prevents cardiovascular disease.
Should people treat at 130 over 80? Should someone be treated?
Yeah, that's a good question. So for low risk patients, they should go on at least 6 months of exercise and diet to try to get their blood pressure down. And if their blood pressure is above 130 over 80, after they've done all of sort of that style change, then they should be considered for blood pressure medicine. Now, if they have diabetes and they're above 130 over 80, they get put straight on blood pressure medicine in addition to behavioral change.
What do you like
So,
to start with in terms of a medicine? What's your first choice?
oh gosh, I mean, that is a good question. It depends on the patient population. I think if we're going to talk about diabetes control, I probably would start with an ACE inhibitor just because of the data on kidney protection and heart protection for diabetes in patients with high blood pressure. I think patients with salt sensitive hypertension can go on a diuretic or a thiazide. Um, for patients that have no risk factor, like no chronic diseases except for high blood pressure, I try to keep it really easy in the clinic. So sometimes I'll just put them on something like a vasodilator, like um, a calcium channel blocker. And then I don't have to, the patient nor the physician have to order labs. Because if you put someone on something that's impacting the kidney in a positive way, and sometimes, it still can affect the kidney in a negative way. So like an ACE inhibitor, I have to track their blood, I have to track their labs after I start them. Now it's worth it. And I only have to do it one time as long as their kidney function stays normal. But in a patient that doesn't want to have labs, then and they don't want to be on a diuretic and pee and all those things, then I'll put them on something where it's just a vasodilator and I can get their blood pressure control without needing to do repeat labs, if that makes sense.
It does. And I want to now, first, I always ask Andrew if he has a question from what he's heard, because now we've talked medicine for a half hour or more, and Andrew's been sitting patiently listening to all this as our test subject on what other people who
Mhm.
listen to this podcast might have in mind. What are you thinking, Andrew, at this point?
Well, I've done my blood work and I actually pulled it up and I'm right in that
It it's like right outer band of high, but I eat right, I exercise, take supplements. I do have history, it looks like, of
You
cardiovascular.
have terrible history.
Yeah, so
Your grandfathers and your father all
right
have
now I'm on a
bad
supplement
history.
called cholesterol, which is supposed to help a little bit for that.
Hmm.
At what point do I go, okay, it's time for medication intervention?
Well, I mean, you're the typical patient that comes into my office, and so the next thing I'm going to ask you is actually, what is your LDL?
Which one? I have LDLP, C, and then
LDL-C?
LDLC is 116.
Okay. So that's not a bad looking number if the goal is to get it to 100. I think one thing that I would say is we would need to look at, is your hemoglobin A1C normal? That's your glucose control. Is that number normal?
My
I'd be
glucose.
shocked if it wasn't normal.
Yeah.
Yeah,
Is your
it's normal.
Okay. Your blood pressure is normal. Like all these are things where like when we talk about the risk calculator, if you put all your numbers and your age and everything in, would you be normal?
Got it. Okay.
And so then if you are, let's say this is like the perfect example. You are low risk. Okay, let's just assume like you're low risk. Your blood pressure is perfect, everything's perfect. And you just told me that you have a terrible family history. Okay.
Terrible.
Terrible. So, what I'm going to say is, you came to me to make sure that I was appropriately treating you based on your risk. And so then I would say, you're in the office already. Let's draw a lipoprotein A.
Got it.
And if your lipoprotein A is elevated through the roof, I'm going to say your LDL target needs to be lower.
Got it.
It probably needs to be more around 70. And
Yeah.
so even though 110, I mean, almost everyone will say, "Oh yeah, that's pretty good. That's not too bad. It's around 100." But if your lipoprotein A is really high, you have a risk factor that needs to be treated.
Okay.
He's got both grandfathers and a father with cardiovascular disease, including coronary disease. So,
Yeah.
yes, he definitely would fall into your. So there you go, Andrew. You can do something about that if you need to.
Yeah, I need to look
Susan,
at the LDLA, I guess, and see
what other questions have you got besides
where's
one
a
on
where is AI coming to factoring with
good
the health
question?
risk calculators, um, and even sort of like differential diagnosis when you're determining um, next steps for a patient. Are you using AI in that form?
I don't I think this is where I think AI can really come into play. I think I think as a preventative cardiologist, we know what causes heart attacks and we know the risk enhancers. I think where AI really comes into play, and I'd love to collaborate with anyone that wants to do this, is that we need to do better population based screening in our health systems. So we should use AI, leverage AI to basically calculate a risk across the health population, pull that coronary calcium from their CT if they have a CT already, and then decide across the health system, leveraging AI, able to do that very quickly and say, where's our high risk population? Let's treat them more aggressively to reduce our population risk of CVD. So AI can be very powerful. It doesn't need to create a new risk marker or find a new risk marker. Honestly, what it needs to do is take the population, the electronic medical record, and pull those existing risk factors, put them into an ability for us to determine who's high risk, and then for us as a health system to go out and treat them.
Susan, this has been exactly what I hoped it would be. I wanted to cover these risk factors. We just got finished with cancer with Terry Beavers, and now we're going after heart disease and preventative risk and screening. And I don't know if we'll do pulmonary disease next. I have to go find someone to do that, but we'll find someone. But thank you so much. If you have any other questions or any last words, go ahead.
No, thank you so much for letting me be on. It's been fun. And, I think prevention is the most important thing that we can do. And the other thing I would say is, as a cardio-oncologist is, and what I learned being a cardio-oncologist is a lot of the risk factors that we talk about, they're overlapping for other chronic diseases, cancer in particular. So if you're treating your blood pressure, if you're treating your BMI, if you're staying healthy, you're preventing heart disease, but you're also preventing cancer.
Thank you so much for joining A New Prescription. We're so excited that you stopped by. Please join us on our social pages at A New Prescription, and also subscribe to our YouTube channel at A New Prescription YouTube. Remember, your health is the most important thing to you. We'll see you next time.